Hello, this is Dr. Sanjoy Kumar Rai, Registrar Medicine, Khulna Medical College Hospital. This video is for medical student. I would like to talk on the innate or inherited defense mechanism of our pulmonary system. That means, how does the pulmonary system work by its innate defense mechanism? As we know, the pulmonary mucosal tract lined by ciliated epithelium, and also there are a good number of mucus secreting cells. So the innate immunoresponse or defense mechanism of the respiratory system started from the mucus and cilia. So secreted mucus reside within the respiratory tract, that is bronchus and bronchioles, and cilia are located here circumferentially. When any particulate matter are inhaled by us and the particulate matter enter into the airway space, that is bronchioles, at first the particulate matter are suspended by the thick mucus. That means it is the first barrier against the particulate matter, and being suspended within the mucus, the particulate matter cannot go further into the lower respiratory tract. Then the cilia try to clear out of the suspended particulate matter from within to outer world, and ciliary movement occurs in such a way that the particulate matter from here to move outward, and when the particulate matter are enough in amount, this particulate matter stimulate the cough reflex, and by a vigorous coughing, this particulate matter expel out with somewhat mucus, that is we call sputum. So sputum production following cough is a good physiological response to remove any particulate matter from your respiratory tract. Now, this is the physiology. In cigarette smoker person with cigarette smoking, the mucus secretion is somewhat increased due to stimulation of the mucus secreting goblet cell. So in cigarette smoker, mucus secretion is increased, and as we know, the smoker person has a tendency to produce more cough than the normal person, non-smoker person. Okay, but on the other hand, in cigarette smoker person, the ciliary movement are decreased, and at times come when the amount of cilia, number of cilia also decreased. So as a whole, the ciliary function become defective in a smoker person, and mucus secretion, amount of mucus secretion is increased. So in cigarette smoker person, think for a moment, the increased mucus remain inside the airway like here, and it is bronchioles, that is lower respiratory tract, and as the ciliary movement is defective, so any particulate matter, if here and suspended within the mucus, cannot be cleared out by the ciliary movement. So particulate matter, even any virus or bacteria, organic materials or inorganic materials suspended within the mucus in the lower respiratory tract, predisposed to lower respiratory tract infection. So smokers are the person who is in increased risks of lower respiratory tract infection, and sometimes this lower respiratory tract infection may lead to pneumonia. So from this point we can conclude that the cigarette smoker person are at increased risk of lower respiratory tract infection with increased chance of pneumonia. Okay. Now some other point, there are some rare disease that are responsible for decreased ciliary movement other than cigarette. Okay, what are the diseases that are responsible for decreased ciliary movement and that also responsible for the lower respiratory tract infection in increased rate and also pneumonia? So the disease which are responsible for the decreased ciliary movement are Carter syndrome, very well known to us, Carter syndrome. In another video I will talk on this point. Another one is Young syndrome, very rare, Young, Y-O-U-N-G, Young syndrome. And number 3, ciliary dysmotility syndrome, very rare. But the Carter syndrome is rare but not so very rare and clinically very important. All these rare syndrome predisposed to development of number 1, sinopulmonary infection. That means infection of the sinus, that is paranasal sinus, and leads to sinusitis. Okay, frequent sinusitis, headache, pain around the jaw, etc. So sinusitis, and number 1, pulmonary infection, that means lower respiratory tract infection and pneumonia. So in this case increased risk of sinopulmonary infection. And number 2, bronchiectasis. Bronchiectasis means ectasia means dilatation, as the secreted mucus are plaque within the lower respiratory tract and they cannot be cleared off by the ciliary movement. So this increased amount of cilia associated with increased infection leads to damage, necrosis and fibrosis of lower respiratory tract muscles and other structure that leads to dilatation. Okay, so this is called ectasia, bronchoectasia, that is bronchiectasis. Okay, hope you understand it. Now, so I already talked on the point of cilia here. Okay, now I would like to talk on mucus. There are some antimicrobial agent present inside in the mucus, in the secretion. What are the microbial agent or component present in the mucus? They are number 1, some antimicrobial peptide. They are defensin, immunoglobulin A and lysozyme. All these are antimicrobial peptide. If any microbial agent like bacteria, virus or fungus even enter into the respiratory tract as a particulate matter, this component will attack and take part in the damage and removal of that microbial agent. Number 2, this is the number 1, and number 2, some antiprotease. The most important antiprotease I would like to talk on later, alpha 1 antitrypsin. So antiprotease, and number 3, antioxidase. However, these 3 points, antimicrobial, antiprotease and antioxidase, all these components act synergistically in a normal person in the process of opsonization. What is opsonization? We know better. And killing of the bacteria. Okay, this point act synergistically in the process of opsonization and killing, removal, destruction of the not only bacteria, any microbial agent. Okay, any microbial agent. Now finally, very shortly, alpha 1 antitrypsin. Actually, alpha 1 antitrypsin is a antiprotease. In any inflammatory process, we know there is inflammatory cells like macrophage and most importantly neutrophil entered in the place of inflammation, and they take part in the inflammation by producing some cell-destructing, I would like to emphasize on that point, cell-destructing enzyme. Okay, neutrophil produce this enzyme, and neutrophilic elastase is one of them, and these elastase destroy the elastic tissue that are protein. Okay, and if excessive function of the elastase occur, that means excessive destruction of the elastic tissue will occur. So excessive destruction of elastic tissue in a foci of inflammation is regulated by the counter-regulatory component that is called alpha-1 antitrypsin. Okay, this is normally present in the mucus, that is in the secretion, and this is the component of our innate immunity. But if any person are deficient of this alpha-1 antitrypsin, what will occur? The problem will occur in a patient with alpha-1 antitrypsin deficiency. The neutrophilic elastase function will be high or will not be countered. Okay, so excessive function of the neutrophilic elastase in the foci of inflammation will destroy the normal elastic tissue in excessive amount and leads to fibrosis and ectasia. Okay, so alpha-1 antitrypsin deficiency patient will develop premature emphysema. We know emphysema develop in some patient with COPD very later in life, but this emphysema occurs very early life, say 15 to 25 years old man or woman, he or she not a smoker even, but develop emphysema. So this is the clinical point. Now last point, macrophage. Macrophage is another important component of innate immunity. We know macrophage can destroy any microbes, mind it, any organic dust, mind it, and any other particulate matter, mind it, but the macrophage cannot destroy inorganic agent. This is the point, clinical point. Macrophage can engulf and destroy these point, but macrophage cannot engulf and destroy this point, that is inorganic agent cannot be engulfed and destroyed by the macrophage. So what are the inorganic agent? Most importantly, asbestos and silica. These 2 points clinically very important, asbestosis and silicosis, that are responsible for pulmonary fibrosis and chronic interstitial pneumonitis also. So these 2 most importantly inorganic agent which are not managed by macrophage, and these asbestos leads to I took some point in wrong. This inorganic component asbestos and silica can be engulfed by the macrophage, but they cannot digest, they cannot process it further. So the engulf asbestos or silica leads to the death of the macrophage, and the death of the macrophage release some proteolytic enzyme, and that proteolytic enzyme leads to the lung damage, and these lung damage is the clinical features of asbestosis and silica. Mind it, the clinical features of asbestosis and silica very similar, overlapping. So this is all about some point regarding innate immune system of our lung with some clinical correlation. Thank you.